as patients can see, menopause looks very different on everyone. So I think that the education on Hispanic women, African-American women, in that, we're less than 1% of the research, right? So we're just going to lead the charge. So we have some questions that have come through, and let me get this here. All right, get that pulled up here. I have them on my paper and I have them on the app. Okay, here we go. So get this, pull this up here. All right, so the first question is going to be Siobhan. I'll read it and then you can answer.
Okay.
Siobhan, I'm 67 years old. Am I too old for hormones? What do you think?
Yes, I'm sorry. Oh, I'm just kidding. No, you're not too old for hormones. So whatever research there is on menopause, there's not a lot. And a lot of it says, hey, you get the most benefits in the first 10 years, right around menopause. However, that does not mean that if you're 65 or older, you cannot get some benefits. So estrogen is bone protective, brain protective. There actually was a study last year looking at 10 million Medicare patients, so 65 and older. They found 19% decrease in all-cause mortality, decrease in rates of breast cancer, lung cancer, colorectal cancer, decrease in incidence of heart attacks, stroke. So no, it's not too late. And I mean, most people, when you're 65 or 70, maybe you're a nana, a grandma, grandpa, whatever. I mean, maybe you want to enjoy the grandkids and chase them around and not just feel crappy. So no, it's not.
My aunt who was supposed to come, she's 70, okay? She started hormones at 70 and she feels amazing. She looks amazing. She says, I don't remember the last time I felt this good. She's down 50 pounds. And yeah, I wish she could have been here, but she's doing amazing. So it's a great example. All right, next question is for Taylor. Taylor, sleep has always been a struggle lately. Is it true that more than half of women in menopause deal with this? If so, what's up with that?
Let's all take a nap. No. So 1 in 4 women actually do express sleep issues. And so if you're not sleeping, what you're doing during the day is just going to be half productive, right? So ways that we talk about hormone therapy, like they did today in the show, is how can we support those changes in hormones? Like what's going on with our estrogen? What's going on with our progesterone, testosterone? Why is our sleep being affected? So yes, it is very true, but that doesn't mean you have to deal with it. That doesn't mean we have to be sleepy all day.
Good.
All right, this question's for Alan. Someone mentioned that bone density drops quickly after menopause. How serious is the risk for osteoporosis? And more importantly, what are other options besides Prolia?
So ladies, I know you love hearing from me about your menopause. So I can talk to you about my menopause experience at my house that we went through, and I'll tell you all that sometime.
Tell them about that first consult. Tell them about the first consult.
Oh, yeah.
This is a great story.
It's a great. So I was sitting and talking actually at one point about this lady about her menopause symptoms, and I could tell that she's like, "Listen,
She wasn't having none of it.
She wasn't having it. Like I need to listen to this guy about my menopause symptoms. Great, mansplain them to me now." So actually, I said, "Well, let me tell you about my wife." Then she was interested, right? And so my story always with menopause. We went through menopause at my house. We're still dealing with that. We're in our 50s. It was too hot in our house. I did nothing. It was too cold in our house. I continued to do nothing, and then I was breathing her air, and it was time to get her hormones taken care of. But yes, actually in the first 5 years of menopause, you lose about 20% bone loss, which can happen. And so it's what we're finding with things with like strength training, getting your nutrition, getting your sleep, but then adding some testosterone in can really help decrease that bone loss. And we're actually seeing some research that shows getting on hormones is actually outperforming kind of the gold standard right now for osteoporosis. So I think we're going to see more and more come out. So absolutely important within that first 5 years to prevent that bone loss. And even we're seeing some reversal of it.
It's good. It's good. All right, this question's for Nikki. I've noticed some dryness and discomfort, but I feel embarrassed bringing it up. What are some of my options?
Yeah, unfortunately, a lot of ladies are not comfortable necessarily bringing up that complaint of vaginal dryness, which can sometimes lead to, as the lady talked in the video about, painful intercourse, which if intercourse is painful, then you're never going to want to have them. So anyways, but yes, estrogen is like a lubricating hormone. So not only helps with that joint pain, but also keeps the vagina nice and lubricated. So even the ladies that have history of breast cancer, a lot of those ladies are great candidates for some vaginal estrogen. We like to use some vaginal estrogen with a little bit of DHEA, kind of rehydrates those tissues, kind of brings life back to those tissues, helps with the lubrication, helps with decreasing pain, also helps with like women who are in menopause sometimes because of the lack of estrogen have more incidence of urinary tract infections or vaginal infections. Well, a little bit of local estrogen in those areas can help with those symptoms. So it's a game changer. Yeah.
Okay, I'm gonna take this next one. If hormones are so great, why do doctors say that they're bad, right? So in 2002, there was a study called the Women's Health Initiative, right? And this, unfortunately, it was a good study in that the intention was good, but unfortunately, it was over extrapolated. So there was a couple problems with this study. The first problem of the study is that they use progestins. And so a lot of times when we talk to our patients, what we're prescribing is progesterone or prometrium. That is a bioidentical progesterone that is metabolized differently than progestins. Unfortunately, when you look at research, which I look at research all day, every day, 3 articles a day is my quota, they don't, in the titles, they don't say, oh, hey, by the way, progestins were used. They just say progesterone, right? So then hormones overall kind of got that bad rap. The second thing that went wrong in that study was they call it the hypothesis theory. So the hypothesis theory is research shows that hormones are the most beneficial within the 10-year window of menopause. So that's 10 year before, 10 year after. Now that does not mean you can't have hormones after those 10 years. And that's where it becomes a discussion with experts like us on benefits versus risks, right? So the problem is in that study, they were giving hormones, synthetic hormones, to, unfortunately, nurses who were out of that 10-year window. They were over 65. Many of them were overweight. Many of them were unhealthy, hypertension, and many of them were smokers, oddly enough. And so naturally, their risk of breast cancer goes up exponentially just because of those lifestyle changes and their age, right? Okay, so that was the second thing. What we actually found 20 years later when they reviewed that data is they found that women on estrogen or estradiol actually had a reduction in breast cancer. And not only that, it lowered their cardiovascular risk. And more importantly, it lowers the risk of dementia and Alzheimer's disease. And so if you've been with our practice and maybe you had a longevity panel, and as soon as someone sees that ApoE3 or ApoE4, they're like, oh my God, I can't remember shit, and I have Alzheimer's and dementia. I'm like, slow your roll, okay? Number one, you're on hormones, okay? So that is one of the best things you can do to protect yourself. The second thing that we call Alzheimer's in our practice is type 3 diabetes. So we might be on like a GLP-1 or a little tirzepatide or something. And then the third thing is all the lifestyle things. So exercise. We always say muscle is the currency of aging. And so one of the best things you can do is try to get that strength in, try to get the movement in. And so, again, unfortunately, traditional medicine over extrapolated a really poorly designed study. But what's kind of great is 20 years later, we got to retrospectively look at that study and actually realize, shit, estrogen is actually very protective. And unfortunately, estrogen took the blame for what progestins did. So I think a lot of times when I'm talking to my patients, I am like, well, let me tell you, sit down, pull up a chair. Let me tell you what was wrong with that study. And I say, hey, here's my number. Give it to your doctor. If they want to call and talk to me about that study, happy to have a conversation with them. Just so you know, no one's ever called. I'm still waiting. So I think that is always a big misconception. But again, if you really look at the research and you understand it well, it's benefits versus risk in educating your patient. So we together are making this decision, and I'm not just telling you this is what I need you to do. I mean, sometimes I do, but I usually educate you first. Yeah? Okay. All right. Next question is, let's see here on my list. We've got Taylor. Taylor, I didn't realize menopause could affect heart health. How big a risk is that women are after menopause and heart health?
Yeah, so the number one metabolic killer, I should say, to be quite frank, is heart disease for both men and women. And so if you think, why is my cholesterol raising? Why am I having, my blood pressure? My doctor's telling me, hey, this looks bad, put on a statin, or hey, you need a blood pressure medicine. Usually there's lack of education to why. There's great research that supports that even estrogen is very lubricating, kind of what Nikki was saying for vaginal health, but very lubricating for our vessels. I usually tell my patients, your vessels are like a spaghetti noodle. I don't want it to be thick. I don't want it to be, crunchy. I want it to be nice and al dente. So we really, correlate that to your cardiovascular. But I see a huge change in my postmenopausal women when we do add testosterone and estrogen to what is your cholesterol going to be doing after this? It's usually going to be improving. And so then kind of like Lex mentioned with longevity, if you have better heart health, you're going to have better ability to move. You're going to be with your grandkids. You're going to be with your kids. You're going to have a greater life expectancy. We talk about longevity. So yes, huge, very, very huge for cardiovascular health.
Good. All right, next questions. Is there wait, hold on. Is there something you can do to help with facial hair? We'll go ahead and just direct this to Dickie.
Is there something we can do?
For facial hair.
Oh, for facial hair. That one's a frustrating one because hormones are changing. Unfortunately, as we get older, us ladies like to develop more facial hair. And I will say optimizing testosterone can unfortunately be one of the side effects. I feel like that's probably your most common frustration. And no, ladies, you're not going to grow a beard. Okay, no. It's like you're already plucking a few chin hairs here and there. Unfortunately, you may be plucking a few more. A great management for strategy management for that would be doing our laser. Like if you have darker, more coarse type of hairs, laser treatment works very, very well. However, there's a little device or a little tool like a dermaplane tool that is usually ladies' best friend, or tweezers. But unfortunately, a side effect, all of our ladies that are on testosterone replacement therapy, we also place them on DIM. I'm not going to get in the weeds of this, but DIM also helps with prevention of some of those potential side effects. So if you're not taking your DIM, take your DIM. We also have some other cool supplements that help with lowering that facial hair. Anybody else? Siobhan's got one.
Well, I normally say that if we're having a conversation about testosterone, you probably already have a set of tweezers for your car anyway. So let's at least get you feeling better.
I have a full dermaplane blade in my car.
I think the thing to have a conversation with your provider if you're experiencing those symptoms, you can also adjust the dose, right? And so we talk to you about this range that we want you in. But one of the things that we like to talk to our patients about is I treat you and I don't treat labs. And so if that's truly a concern for you, and again I can say lots of things about my wife here tonight because she's not here, is that her laser appointment is the same time as her pellets, and so she comes in, she gets lasered. But the truth is we can also come down in your dose a little bit and you still get the benefits.
Ellen, there's a question in on the caller line specifically for you.
Uh-oh.
Ellen, tell us about menobelly. Is this really due to hormones or overeating? How does HRT relate to the weight loss?
Yeah. So we see that a lot with the hormone changes, right? And so decreasing, developing that visceral fat. And so I think there's a combination of things. And specifically with women, what I like to say, and I'm going to tell you something that's going to blow all of your mind, is that you ladies are far more complex than us guys, right? Like so many more hormones. And so oftentimes when we optimize your hormones, that you do decrease that menopause belly that we see. So it's not always that you're overeating. It's not always that issue. Sometimes we do have to bring the protein up and the carbs down a little bit, but no, it's oftentimes can be related to your hormones.
There was actually a study that was done where they compared women on HRT and then women on HRT and a GLP-1, and the women who were on HRT versus women, I said it wrong, women on GLP-1s and then women on HRT and GLP-1s. The women on the GLP-1 with the HRT sustained better weight loss compared to women who just took the GLP-1. So it is a real thing. The other thing that I often tell patients too is why the menobelly is our body gets estrogen from really two places, right? We get it from our ovaries. You make a little bit from your adrenal glands, but really adipose tissue or fat tissue, right? So when your ovaries are no longer producing estrogen, your body's natural safety mechanism is to increase its adipose tissue. Well, when you think about your abdomen area, that's your largest surface area, right? Your hips, your abdomen, your butt cheeks, right? So you get a little bit of the cellulite. It's because your body's trying to squeeze every little bit of estrogen it can from its own. So a lot of times, and I always say, hormones are not a weight loss support supplement. You might lose some weight because I'm giving you the estrogen, but it's not. I don't market it as such because they're gonna be pissed when they come back in 6 weeks and they're like, I'm the same size. I'm like, well, okay. So I think that's also important to note. The other thing that I've actually read recently too is women when they go through menopause, their estrogen declines. And so the question is, why all of a sudden these chin hairs, and why is my hair falling out? And why do I all of a sudden have a surge of acne? Like, I thought I was done with that. Well, it's because it's your body's almost having like a rebound withdrawal. So there's a process called aromatization. And aromatization is when testosterone converts down a pathway making estrogen. Well, your ovaries are no longer making it. So your body's like, okay, don't worry, we got this. We're going to crank out some more testosterone. Well, guess what happens? It converts down to another pathway called DHT, and that's where you got tweezers in your car, you got a new zit, kind of showing up. Carmen's trying to zap it with the laser, and your hair's falling out. So there's actual like science behind these metabolites and these pathways, and that's truly why we do all the crazy integrative testing that we're doing, and why we use things like Prostate Supreme in women, is because there's pathways we have to look at to make sure we're doing the right stuff specifically for you. All right, the next question was. Got it on my list here. It says, my GYN said menopause is a season of transition and you just need to get through it. Is this a natural part of aging, Siobhan?
I mean, yes, it's a natural part of aging, but I mean, going to the doctor, you would treat any other disease. You would treat diabetes, you would treat hypertension, you would treat that. So there's no reason why with menopause, you don't have to be treated for it. And so I feel like if this was a condition that happened to men, there would be 100 different treatments for it and it'd all be FDA approved, okay? But because it's not, women are kind of just grin and bear it. So no, you don't just have to deal with it. If your provider says you'll get over it in a couple years, they said it in the video, find a new provider.
All right, perfect. Next question's for Taylor. Taylor, I'm out of the window of menopause. Do I need to stay on my hormones?
I literally just talked to someone about this today. So it's kind of like when you're at a really fun event and you're like, I really don't want to go home. It's like, usually we do, but I say, if you could go home and say, I still had a good time, that's how I explain my hormones. Like, yes, if you start something, why do we want to go back to how we were feeling before? Why not continue that ride through the next, 3 to 4 to 5 to 6 decades after that? So I find if it's not broke, don't fix it. Like, let's kind of keep this roll going. But that could change modalities. We could change methods. Like, if one thing's not working for you, one thing might be working for your girlfriend who also comes to YDH. But what works best for you is what we're going to find. And I can speak for my whole team up here that I know that we are really good listeners. When I went through NP school, I had maybe 2 hours of menopause training. And so most providers that you're going to right now, why didn't they talk to me about this? But they're not listening. It's not because they're meaning to be bad or meaning to not give you the information. They may have 15 minutes with you to talk about 7 things. And so I just find that we have the time, we have the knowledge, and we're here to be your teammates.
That's really good. The other thing to consider after they're like, can you stop commenting on everyone's questions? The other thing to consider is, so we get you out of the window of symptoms, right? One day you'll not have as many hot flashes, okay? Where them fans at? Okay, so what will happen is you're still gonna retain the benefits for brain health, bone health, reducing your breast cancer. Remember I talked about the 20-year aftermath of that 2002 study? Those are all things you can't see. Looking at a bone density, looking at a DEXA scan, looking at all these other things, lowering your cardiovascular risk. I check lipids on everybody, right? And so one of Holly's goals was to be better than me, and I was like, good luck. But it's one of those things that there's so many benefits that aren't obvious, that we as our team, we get to see it on blood work. And so just know that there's a method to this madness. And just because maybe you're out of the hot flash window, there's still so many other things that those hormones are doing for you that you may not realize until then I tell you, like, hey, did you know this? Oh, okay, that's good. All right, there was a really good question about PCOS. So I'm gonna direct this one to Nikki. Nikki, I have PCOS. Will that have an impact on my future menopause?
I mean, I believe so. I see a ton of ladies with PCOS, both young, like in their 20s, who are struggling with, their biggest things are irregular cycles and they're breaking out and having all this hair growth, yada, yada, yada. Like their management of PCOS is different than my perimenopause, menopausal ladies with PCOS. Yes, historically, when they're younger, their testosterone levels are high, which is why they're having all those symptoms. But like everybody else, your testosterone kind of peaks in your early mid-20s and then it tanks. So I have a lot of ladies who PCOS who, are fatigued. They have brain fog. They have no motivation to do the things in life. They're struggling to get through the day. Their sleep's crap. So, I feel like they are great candidates, even though historically testosterone levels tend to run high in my PCOS patients. Again, they usually are tanking in their perimenopause, menopausal years, and they're great candidates for testosterone replacement therapy. I usually dose them more casually than I do those that don't have history of PCOS, and they do great. Yeah.
All right. Alan, on the line here. I'm confused. I heard from my gynecologist that taking pellet therapy orally, I'm not sure about that, was not good for you. Tell us more.
Yeah, so as you've noticed, we're not a big fan of oral therapy. So if oral therapy is what they're talking about, it's metabolized through the liver, and so there's some complications with that. Pellet therapy, I hear that, and again, I use my lovely wife. I hope this is not recorded, but she was on pellet therapy. She's on pellet therapy, and I don't recommend this to my patients, but when I go to my traditional office, they ask me if I'm on anything, and I just say no. It's just not a big conversation I want to have with them. But my lovely wife is a teacher, and she's very honest. And so she told a 35-year-old PA that she's on pellet therapy, and they proceeded to tell her all these negatives about it. So I just feel like they're just grossly uneducated about it. I mean, you're looking at a bioidentical, bioavailable hormone that, again, like Taylor said, just the training on it is just so underwhelming. And so that's why I think more and more, and I think some of the more progressive providers are getting out there and starting to understand this. And I think documentaries like this, hopefully we're going to see some more things with men. I think we need some more spotlight too on the things that we go through. But the pellet therapy, I think oftentimes they make comments about the pellet therapy just because they don't understand it. That's really.
I can't save you. All right. The next question was Taylor. It says, I had breast cancer, and my aunt also had breast cancer. Does that mean I can't have hormones?
I think we've heard it here first, ladies and gents, that is not the case. I think too, this is where in regular medicine there's been a lack of education. I think it's fearful. What is fear? It's the lack of knowing, right? We're not there. You don't have that information. Again, it's a conversation. I say, I'm going to be your teammate. Let's talk about it. Let's get a thorough history. What happened to your aunt or sister or cousin or best friend? Do we have any more information on them? What's going on with you? Where are you at in your therapy? Where, can we still do pellet therapy? Or do things sound a little bit more enticing? Is it time for estrogen? Is it not time for estrogen? There's been really good research that supports that even testosterone therapy alone can support 80% of menopausal symptoms, as well as kind of block those receptors that breast cancer would want to attach to. So we're constantly kind of just paving the way and getting more research, but no, you absolutely could still benefit from hormones, and I would recommend it.
I think, yeah, I do. I think the thing to be aware of, and this is, I get this question a lot, and it hits home. And currently, I think that, the research is showing, let's not talk about hormones. Currently, ladies, you're at 25 to 28% of you are going to develop breast cancer. And that number is rapidly rising, right? And so whenever I hear that comment back to me about that, I like to ask providers, well, talk to me about all of the patients who are not getting hormones, and why are they getting breast cancer? And why is that number getting worse every year? And we're seeing that number incline, year over year. So when I hear those comments, I just go back to, well, talk to me about all the ladies who aren't getting hormone therapy, and why is that number going up in them? So it's really, really scare tactics, I think, more than anything else.
So we get patients with history of breast cancer, and so we have to have this very real conversation. And I really try, despite probably what my mom says, I do try to play nice with everybody. And I try to be open to other people's, medical experience, especially oncology, right? And I am a very big researcher in that. Please let me share the research with you. So there is a phenomenal breast oncologist in Dayton, Ohio. Her name is Dr. Rebecca Glazier. And she is a pioneer when it comes to hormone replacement in women with breast cancer. And so what she has done is she has looked specifically at testosterone pellets. So I can't speak to this research and translating it to creams or shots or Kysotrex, but specifically with pellets. And just as Taylor said, testosterone binds to a receptor. So think about a receptor like an outlet plug, right? Testosterone is like you got the baby who wants to stick the pretzel in the outlet plug. That's estrogen. Testosterone is putting the outlet cover on there. So if you put the outlet cover on there, that's your testosterone. The baby can't stick the pretzel inside the outlet, right? What actually studies show is if we put a little bit of anastrozole in there, so there's a couple different types of estrogen blockers that a lot of times women will go on after breast cancer, tamoxifen, letrozole. Actually, I think tamoxifen is a SERM, it's a selective estrogen receptor modulator. Anastrozole, I think those were the two that I think my mom had tried, and they were terrible. My mom said, I would rather risk getting breast cancer again than having to take this. That's how terrible it was. Brain fog, neuropathy, she was depressed, she couldn't remember shit. Like, it was terrible, and she lived with me, so that I was like front row seat to what this looked like. What studies actually show, though, is that women who replace testosterone with a little anastrozole mixed into that pellet lower their risk even more exponentially compared to women who do nothing at all and compared to the women who do testosterone. So please know when I say that, some of these modalities, especially traditional doctors, there's no research behind it. Yeah, I got it. I'm happy to send it to you. The other thing that I try to do too is I try to get a written clearance from them. I want them to know, hey, I have your patient in my care. I'm going to do everything I possibly can to keep them safe. And I send them the research. And there's one, St. Vincent's oncologist, I can't think of her name off the top of my head, but she has read the research. And so when someone tells me no at community, I'm like, don't worry, girl, I got you. We're going to send you over to so-and-so. They're going to read your case, and then they will give us a true, honest answer. So I'm very lucky that we have found that doctor in particular. So if you have a friend or you yourself are here and you're like, I don't really know, I really want to make sure that my oncology team's okay with this, there is a doctor who is local. I wish Rebecca Glazier was local. I'm trying to get that lady on my podcast, but she's too busy saving lives. So that is a possibility. So I know a lot of my patients have friends. Well, my friend so-and-so said this. I'm like, listen, there are options. And I think we just need to start the conversation and really look at the data and educate people on what are the options. So I think that's really important to know, because I think, again, once we hear the breast cancer word, it's like they shut it down. It's like, whoa, all right, next question. We'll go with Nikki here. Nikki, I thought menopause was just a year or two of symptoms, but I've been told now it can last up to 10 years. Is this really true?
Well, I feel like the video did a great job of kind of talking about that. But average age of menopause is roughly the age of 51. Now, that's not been studied in a long, long time. But unfortunately, women can start having symptoms of perimenopause a whole decade before that. And unfortunately, you can have a whole set of symptoms a whole decade after that. So you're really talking about a long, potentially a very long time if you don't manage those symptoms with a little bit of hormone replacement therapy. Yeah, great. It's just great.
Taylor, if I want to get on hormone replacement therapy, what are the things that I should monitor either yearly or every couple years?
So we have this conversation a lot, screening, whether or not we necessarily believe entirely in what the screening modality is. We're still kind of held to a standard as providers. So I recommend a mammogram every year, or every 1 to 2 years. I still think it's great to still get your pap smears. I think now it's every 3 to 5. That can kind of fluctuate, as well as colon cancer. So colonoscopies usually starts around age 45. I find knowledge is power, and I think we speak to that, researching and reading 3 articles a day by the leader here, that the more knowledge we know, the more power, the better we can treat with hormones and other modalities we have in our office. It's not necessarily, it shouldn't be intimidating, but it should be empowering to be able to have those testing, and then it allows us to just treat you as a full person versus kind of putting the pieces together. So I do recommend screening still.
And then once you start hormone replacement with us, well, we're going to check your labs every 6 months, even if you're doing almost nothing. If you're doing hormones with us, we can guess what the dose is going to be, but we always want to know, number 1, how are you feeling? And number 2, what do your labs show? So we always will look at, probably about every 4 months, we're looking at your testosterone, your estrogen, your progesterone. and your FSH. So that from a menopause perspective, we're always going to be looking at those numbers.
I would like my friend to get more educated on hormones, so she'll do it too. Do you have any recommendations, Siobhan, on where I can send them?
Well, I mean, you could come and see us. Obviously, I'm biased. I mean, I think this video is a great tool. You can send this to people. It's actually on PBS. So that's a great, it's free resource on PBS. It kind of opens a conversation. I think there's a couple great podcasts, ours being one of them, that has resources on this. And then, I mean, honestly, sometimes the best testimony is the one that you live. And so people, most of the time I meet someone, they come in 3 months later, they feel amazing. Then I meet their husband, then I meet their best friend. And so, you know, part of you sharing your story with hormone replacement is like, they'll see, why are you in such a good mood? Why do you feel better? And honestly, that's normally a lot.
That's good. There's actually a really great book called Estrogen Matters. And it was a book that was published by one of the investigators of the WHI. His name is Dr. Avram Blooming. And he basically went through all the flaws of that study and actually what in reality estrogen actually does for women specifically. His woman is also a breast cancer survivor. So I think that's a really great book. There's a couple new books. One's by Dr. Marie Claire. She kind of, I think she's got great research. She doesn't love pellets. And unfortunately, I think pellets kind of can get a bad rap. And I know some of you have come to us from other pellet practices. And I think you will know we do things very differently. We're always checking labs. I'm always asking you how you feel. I'm always tweaking this. I'm like, let me check your gut. Let me look at your hormone metabolites. And so unfortunately, I mean, I think it's good that there is a rise of hormone replacement providers, but just like everything, you know, we have to make sure that we're doing the education, that we're monitoring the labs, that we're looking at the metabolites. And so unfortunately, it's kind of like, you know, one bad apple ruins the whole bunch. And so sometimes when you talk to your doctor, and so you say the word pellet, they're like, oh my God, it's like, calm down. Okay, let's talk about where I go. Literally, there's an OBGYN locally who will ask a patient, where do you go? And when they say Yoo Direct, they're like, okay, cool. I'm good with that. So yeah, unfortunately, I think that can be really, really problematic for that. So I think those are all the questions. Is there any other questions in the audience that you feel like we didn't cover? All right. Excellent. Well, thank you guys so much for coming. And yeah, you guys are going to get a survey if you have any suggestions for future educational opportunities, or if you think that this would be something that maybe more friends would want to do. We've talked about maybe doing it again. So yeah. Thank you so much. Thank you for